Hi, I'm Heather Kahn. When we think of vaccines, we probably think of protecting our children from various diseases. But what if a vaccine could treat certain types of cancer? Joining me now is Dr. David Avigan, Director of the Blood and Bone Marrow Transplant Program at Beth Israel Deaconess Medical Center. He is a scientific leader in developing and testing cancer vaccines. Dr. Avigan, so good to have you with us. Describe for me, what is a cancer vaccine? What does that mean?
It's a great question, and as you said, I think people's notion of a vaccine is really to protect against infection, particularly during childhood. What we're trying to do with the cancer vaccine is to train the immune system to see cancer cells as foreign and to go after them. The cancer does a lot to hide itself from the immune system and to really fly below the radar screen to avoid being detected. But we found that one can actually re-educate the immune system to see those cells as foreign and to then attack them.
You make it sound like cancer is very smart and very stubborn.
It is, and I think one of the key points in making an effective vaccine is really understanding that sort of wiliness of the tumor cell and sort of really trying to outsmart it. We know that what tumor cells do is they present themselves to the immune system similar to the way that normal cells in the body do, so that they're not detected. What we're trying to do is to change that dynamic by using certain very powerful teaching cells called dendritic cells. They basically instruct the body what belongs and what doesn't belong, and in this way you can actually teach the immune system to see cancer cells as foreign. The reason why that's so important is that a lot of the struggles we have with chemotherapy is that it doesn't do a great job sometimes of distinguishing normal, healthy tissue from the cancer cells, particularly rapidly dividing normal tissue. What we hope to do with a vaccine is to use the selectivity of the immune system, its ability to sort of identify what doesn't belong and to leave alone what does belong, and to use that selectiveness hopefully to have an effective therapy that also would be less toxic.
Okay. How are these vaccines developed?
Well, what is done is that we introduce parts of the tumor to the immune system in the inflammatory way that cause the immune system to react to it. What we've done has been to take the patient's own tumor cells and fuse them together with immune-stimulating cells called dendritic cells that are these very important teachers of the immune system. In that way, you have a combined cell, what we call a hybridoma, that now has the whole array of tumor proteins, including ones that are unique to a given patient, but now puts them in the context of these stimulatory signals so that it causes a broad immune response that targets multiple different aspects of the tumor and in that way can be effective in getting rid of it.
So these vaccines are specifically tailored to the individual patient?
That's right. We take the cells, the tumor cells from that patient and fuse them with these immune stimulating cells that we grow from that same patient. So it is a completely personalized vaccine.
Hearing this is obviously so exciting. My hopes are high. What have you found in your research? What are you seeing?
Well, the first studies that we did were what we call phase 1 studies, where you're looking at a new agent, trying to understand its toxicity and sort of define its safety and look for clues about its effectiveness. What we saw was that in general this was well tolerated, and we did not see, for instance, a lot of activity of the immune system against normal tissues. The second thing that we saw was that a majority of patients, and this is across a couple of different cancers, including breast cancer, kidney cancer, multiple myeloma in the initial studies, developed powerful immune responses against their own tumor that we were able to measure in their blood. The second sort of stage of studies that we've been conducting are looking at trying to incorporate this vaccine into other therapies where we think the setting is going to be really conducive, what we hope will be, I should say conducive, to getting rid of minimal disease that lives on after standard treatments. So we've recently completed a study with patients with multiple myeloma, a type of blood cancer, where after they go through a standard transplant where the disease is put to a very low state, they then go through a series of these vaccines. And in that study we were able to show that many patients get into remission, including those only after the period of vaccination. We also looked at patients with kidney cancer who underwent a nephrectomy where their kidney was removed but still had metastatic disease left behind, and were able to show again that a subset of those patients could be put into either a partial or complete remission using the vaccine.
With fewer side effects than chemotherapy, I'm guessing.
Yes, we haven't thankfully seen a lot of side effects. There is some effect of the immune system being stimulated. We've seen patients have reactions at the site of the vaccine, which we think is a good thing. We see sort of inflammatory cells invading that area. And we've seen some patients with things like fever or itching that we think are sort of things that you see when the immune system is stimulated, but thankfully not a lot of toxicity.
What are your next steps in this research?
Well, as you pointed out early on, that we have to really understand what are the steps that the tumor takes to avoid being detected by the immune system so that it can't reset things and escape the vaccine. That has to do with understanding the principle of tolerance and how tumor cells hide. We are now looking at a new antibody that blocks one of those key tolerizing pathways and using that together with the vaccine in treating patients with leukemia, myeloma, and kidney cancer in separate studies. And we also hope to move into phase 3 studies where we can look at the vaccine in conjunction with standard therapy versus standard therapy alone to really define what impact this has on long-term outcomes, most importantly survival.
I can't think of a career where there's more riding on it. Do you think about this all the time? Does it become sort of an obsession?
Sure. I primarily take care of patients in addition to having this research career that really benefits from a wonderful group of people that we work with. And I think we learn a lot of humility when we take care of patients. We learn that this disease is tough and that there's a lot of steps needed to actually make major breakthroughs, but that is clearly our patients give us tremendous incentive to keep pushing forward.
All right, such interesting work that you're doing. David Avigan, an honor to have you with us today.
Thank you, my pleasure.
Dr. David Avigan, Beth Israel Deaconess Medical Center.